Welcome back to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine with experts from around the country. In this episode, we're going to continue our discussion with Dr. Arianna Gianakos and focus on different injection options for plantar fasciitis, as well as surgical treatment for recalcitrant cases.
Our conversation picks back up with an article from the June 2024 issue of Foot and Ankle Surgery titled Platelet-Rich Plasma Therapy versus Other Modalities for Treatment of Plantar Fasciitis. This Level 1 systematic review and meta-analysis found that PRP resulted in significantly greater pain reduction compared to corticosteroid injections, shockwave therapy, and placebo. PRP also demonstrated improved AOFAS functional scores compared to corticosteroid and placebo. However, PRP did not demonstrate consistent superiority across all outcomes, potentially limited by the heterogeneity in PRP preparation methods and variability in study quality.
We finish up our discussion today with an article titled Nano-arthroscopic Plantar Fascia Release Technique. This technical note, published in the November 2024 issue of Arthroscopy Techniques, describes a minimally invasive, single-portal, nano-arthroscopic plantar fascia release technique for patients with plantar fasciitis. Compared to open and traditional endoscopic techniques, this nanoscopic approach aims to reduce post-op pain, minimize soft tissue and neurovascular injury, and enable faster recovery with early return to weight-bearing and activity.
Plantar fasciitis is one of the most common causes of heel pain. The revolutionary and innovative solution from push braces focuses on actually relieving this strain. The taping concept focuses on effectively relieving the plantar fascia by helping it to support the arch. Push foot brace FP directly alleviates pain, allows you to recover and to move freely at the same time.
The best way to understand the difference is to wear one. Email samples@bracelab.com and mention the Sports Docs for a free brace sample. Explore the full line at bracelab.com. Are you still spending valuable OR time prepping grafts? If so, you should take a look at what JRF Ortho is doing with pre-sutured tendons. They actually offer one of the most comprehensive portfolios out there, covering everything from ACL to PCL, Achilles, and even AC joint procedures. One option getting a lot of attention right now is the SpeedGraft Quad Link. It's designed for all inside ACL reconstruction with consistent sizing, 64 to 72 millimeters in length and 9 to 11 millimeters in diameter, so you know exactly what you're getting every time. And JRF Ortho is the only provider offering a pre-sutured BTB, the pilot graft, giving you even more flexibility depending on your technique and preference.
The big advantage here? Efficiency and consistency. No autograft recovery, no graft prep, no construct assembly. Just a ready-to-implant solution that helps reduce OR time and eliminates donor site morbidity while delivering reliable, high-quality grafts. JRF Ortho has distributed over 30,000 allografts worldwide, and their focus is simple: providing high-quality allografts to surgeons so they can improve the quality of life of their patients. If you haven't explored pre-suture tendons yet, this is definitely worth a look. Visit jrfortho.org to learn more. JRF Ortho, 20 years of excellence in motion. All right, so in part one, we discussed different bracing options and different therapeutic exercises, including both formal PT and structured home exercise program for the conservative treatment of plantar fasciitis. We're now going to shift our discussion to a third component of non-surgical care for plantar fasciitis, and that is injections, starting with cortisone injections. So, Arianna, what are the pros and cons of a cortisone injection for plantar fasciitis?
Yes, so this is something I utilize often in the right patient. Usually we reserve this for patients who have failed other conservative interventions such as physical therapy, heel cups, anti-inflammatory medicine even. And oftentimes if patients have persistent heel pain, this is when I will sometimes consider getting an MRI to really assess the plantar fascia itself, see if it's thickened, see if it's inflamed. That gives us some information on the severity of the injury. And this also makes the patient usually more comfortable in possibly pursuing another treatment modality that might be a little more invasive, like an injection. I find steroid injections to be very beneficial when used in moderation. The reason we utilize this type of injection is really to help reduce inflammation. So part of the reason patients are having so much pain is they cannot get rid of this inflammation that's at that insertion. And a steroid injection can help really reduce this and provide a lot of pain relief. And the goal is really to only do one injection. Now, if someone has an injection and say it lasts 6 months to a year and they have a busy life and they can't really do much more else, will we repeat this? Oftentimes, based on the patient, sometimes we can repeat it, although one is really the max that we really try to do. One thing I will say though, I always warn patients that with any steroid injection, sometimes you can get what's called attrition. So you can get some wear and tear in that region, and you can actually get a plantar fascia rupture in this area. Now, it's very rare. It doesn't happen often. But one thing I tell patients is that if it does happen, you've essentially performed the surgery that we would end up having to do if you had chronic plantar fasciitis that did not get better, or if you had a plantar fascia rupture, which is to release the plantar fascia insertion. So it's not one that patients want. It's not fun. And usually it does take a good 6 to 8 weeks to heal from if it does happen. But I think a steroid injection is very reasonable for someone who is really trying to avoid surgical intervention because it can help reduce inflammation in that region.
That's awesome. So, if you have that injection and it's either not successful or partially successful, and you're like, I really just don't want to move on to a second injection. It hasn't been that long for cortisone. Would you move on to PRP? And what is the time and consideration for PRP?
Yeah, so I do recommend PRP as a treatment option in patients who really are trying to avoid surgery. So PRP, platelet-rich plasma, it's very easy because it is the patient's own material. So essentially the patient will come in, we draw blood from their arm, we then centrifuge it. So we really condense it to get the real good stuff. So the growth factors, the platelets, the plasma, all of these things which can help enhance repair. It also can reduce inflammation in the area, which is really helpful. And once again, it's not a steroid, so actually the benefit can be much more if the patient does well with it. Now, the problem with PRP, once again, is that sometimes insurance doesn't cover it. So this is something that is usually out of pocket. But there have been studies that demonstrate good efficacy with it. Usually what will happen is I'll have the patient come in, I put them in a boot for about a week afterwards, just to really give them some support. Can they walk on it? Yes, I do allow them to walk, but I usually provide them with crutches because just the area of the injection can be sore for the first week after. And then within 1 to 2 weeks, I start them with physical therapy again. I want them to avoid high impact activities though for about 6 weeks after the injection. I do tell patients that this can take up to 3 months to really kick in and work. And so I do like to give it a 3-month period to see if it can help. And typically I just do one injection, although if someone's doing really, really well and 6 months later they feel like they want a second one because they've done really well, I often will offer a second one based once again on the patient and how they've responded to that first injection.
Yeah, and PRP, I feel like in most conditions that we use PRP for, it makes sense because it stimulates healing. So this is like a degenerative wear and tear condition, and this can actually stimulate healing as opposed to just bringing down the inflammation. So it sounds like a really great option. And our next paper kind of dives into this. So the next paper is yours. You're the senior author for the systematic review and meta-analysis, and it investigated the effectiveness of PRP compared to other conservative treatment options for plantar fasciitis. So can you give our listeners an overview of what your paper found?
Yeah, so we basically were trying to look at all different kinds of conservative treatment modalities just to see, first of all, which ones were beneficial. And then if PRP was truly something that we can utilize in the toolbox that was at least as effective, if not more effective. And we did find that overall, there were really good clinical outcomes following the use of PRP injections, and that it was superior in some of the various variables that we were looking at, including pain control afterwards and return to sport. So a lot of this is very helpful to know because once again, this is something where we're not using a steroid, which does have some damaging effects sometimes and is not something that everyone wants to use. And you really shouldn't repeat it too much in the same area. But this is someone's own healthy tissue, own healthy plasma that they're using that can really enhance the repair. So I think that it can be used as a modality if you have the ability to do it. Typically, patients don't get worse after using it, although I do warn patients that sometimes everyone's different, and it does stimulate basically an immune response to the area. So the first couple days can be very painful following this. Everyone's a little bit different though. But I think if you have the ability to do it, it's not necessarily wrong to try, as long as you understand that you may or may not get full benefit in return. And that's how I approach this injection, as well as some of these other treatments. I say what works for, you may not work for your family member. And what gets you back maybe 50% could get someone else back 100%. And you might still need that next step. And just like physical therapy works for X amount of people, but it didn't work for you, PRP may work for X amount of people, but it might not work for you. And I think setting that expectation is really important, and having a good open dialogue with the patient really helps you both navigate if that's the best next step for that patient.
Yeah, I think that makes a lot of sense. And, given all of that data, we'd love to hear, how do you summarize your approach to injections? So, obviously you're trying other things first, whether it's physical therapy or things that they're doing at home or inserts. But as far as would you ever consider injecting someone at the first visit, or, how do you sort of put that algorithm together?
Yeah, that's a great question. And I think it's hard to say because it isn't one size fits all. I think as far as I sort of lay out where we have one end of the spectrum, which is completely conservative, and one end, which is surgical, which I know we'll talk about in a little bit. But I think just like you said, I lay out everything. I talk to them through the whole process at the first visit, where I say, we have the heel cups, we have the shoe wear, we have the physical therapy, the shock wave, we have these injections, all the different kinds of injections. And then we have some surgical options that we really reserve for people that maybe have symptoms for more than 6 months, even a year. We really wait on that because majority of patients, almost 90% of patients, really should get back without having surgery. And then as far as the algorithm of who gets what, I have that as an open discussion with the patient. I typically don't inject the first visit, although if I have a very active athlete who is in the middle of, they've been doing all this training, they are working with a trainer, they are doing all the stretching and strengthening, and they need to get back to sport quicker, that's where I might jump a little bit to an injection and speak with them. If they need to get back, say they're in the middle of season, with a steroid injection, I like to keep patients off the foot for about 2 days. And I don't mean off like not walking, but I mean no high impact for 1 to 2 days after that injection, just to let everything calm down. And then within a couple days, they can start ramping back up. With PRP, I usually keep them out a little longer though, because that really is more of a treatment to heal that area, as opposed to, like you mentioned before, just reduce that. So I think it does depend on their history, how long it's been going on, what treatments they've tried, how invasive they want to be, and then also just understanding what their goals are. What do they want to get back to? What's their timeline? Sometimes people have a trip coming up and they're like, I don't want the injection now, but I want it right before I leave for this trip. So, it's really just understanding what their goals are and trying to come up with a plan that's really tailored to them.
Absolutely.
Awesome. Well, that is a really great rundown of kind of the summary of how we approach conservative treatment for plantar fasciitis, which we should mention for our listeners. If you're an impatient patient listening, it has a high overall success rate, so give it a chance. But some patients are going to fail conservative treatments, and there are surgical treatments available. So we do want to talk about that. So you talked a little bit about your indications, but can you just kind of go through it again, your indications to proceed with surgical intervention and any imaging you're getting to guide your decision of surgical intervention?
Yeah, so I typically will get an MRI prior to surgical intervention, just because I really want to make sure there's nothing else that could be in that area. Another thing that we consider is there is a nerve that runs from the lateral aspect of the foot, so the outside of the foot, into the medial aspect, into that plantar fascia region. It's called Baxter's nerve. And sometimes that can get compressed, which is a slightly different variant of heel pain. It's not as common, and a lot of the times it's all bundled into the same types of treatments, but it is something to consider that we think about. So I do like an MRI though, just to make sure there's nothing else going on. Another thing that we're actually starting to conduct some studies on is looking at if there's bone edema in the insertion point in the calcaneus, because I do find that patients who have a little bit of edema in that bone, and for listeners, edema is just extra fluid in that area, so swelling in the bone. So I always compare it to, if I got punched in the arm and my arm bruised, you see the darkness from the bruise. So that's similar. If we punch the bone, it's going to bruise, same thing. And I find that these patients who have that type of edema, they actually have longer symptoms. And that's something we're looking into now. So just so that we get an idea of prognosis. And then as far as indications for surgery, a lot of the times I do want them waiting a minimum of 6 months, even a year usually. Oftentimes I am not seeing a lot of these patients because they've tried, other doctors or their primary care doctors first, and they've tried the physical therapies for 3 to 6 months already. And then they're coming to me because they feel like they're at a loss. So a lot of the times the people I do end up operating on are already 6 months to a year out. But I would give it up to a year if you can before jumping into a procedure, because the procedure will have variable results. And the reason for that is, if you tear a ligament and you repair the ligament, we know we're putting the ligament back together. Same thing with the tendon. Same thing with a bone. You break a bone, we're putting the bone back together. This is slightly different because this is a degenerative issue. This is an inflammatory issue. So just like I had mentioned before that 80% of people might do well with PT, but 20% maybe don't. And maybe 80% do well with the PRP, but 20% don't. Same thing with the surgery, the same concept that it could work, but there might be a chance it doesn't get you as much as the benefit that you might want. Although I think overall the studies that we're conducting now are very promising with regards to outcomes. And I think it's we have good surgical options now that are more minimally invasive so that the turnaround and healing is a lot more expedited.
That's perfect. You're going right into what we want to talk about next, Arianna. So you recently published an article on the nano-arthroscopic plantar fascia release technique, which we're super excited to dive into. But before we do, just like big picture for our listeners, what does surgery for plantar fasciitis actually consist of?
Yeah, so it's a great question because there are a couple different methods, and based on the person you're talking to and based on the doctor you're talking to, you might hear different things. And so for me, one of the more common procedures I do is where we actually release a little bit of that plantar fascia. So usually the medial and middle third of that band, which is that area that is consistently inflamed, that the patient is not able to heal in. And the reason they're having pain is because it's pulling. And that tissue is not great. So it's not something that we can stitch up and plug into the bone and say, okay, it's going to heal in. So what we end up doing is we actually can release part of it, and it won't drop your arch. It doesn't affect your walking, but it does release the part that's irritated and constantly pulling and trying to heal so that you no longer have that pulling sensation and pain when you're walking. Now, for patients who have tighter calves, another type of procedure is where you lengthen the gastroc muscle so that you're lengthening that. And that's a really good procedure for patients who do have tight calves. The only concern with that, which actually we had published on this several years back, was that in athletes, when you do that, you can lose push-off strength and power. So it is, a lot of my patients are younger, active, and even patients who are well into their 80s still running around, and they don't want to lose that strength. So I tend to avoid that unless someone really does have what's called like an equinus contracture where they're really, really tight. So those are two of the strategies that are typically used in surgery.
So now for that plantar fascia release, there's like open, traditional open, mini open, and then endoscopic. Can we start with open or mini open first? What are the benefits of doing something mini open versus going right to an endoscopic procedure?
Yeah, so traditional ways of treating this would be an open procedure or even a mini open, which is just a slightly smaller incision where you dissect down, you are able to visualize the plantar fascia through that open approach. And then you can either use a blade or a scalpel or a scissor to really release that and dissect that off the bone. And this was something that patients did well with. But if you think about the concern and the pathology of the plantar fasciitis itself, it's an inflammatory issue. So unfortunately, when you're making a large incision, your body still needs to heal that. And then all of the good stuff that comes to that area to heal it starts building scar tissue. And that can cause, once again, a buildup of scar right in that insertion, which then leads you back to where you once were. So it's important to start physical therapy right away, but it is something that had been concerning because it is a large incision right over an area that you're trying to walk on. And it can also cause a lot of inflammation in that region, which is what you had to begin with. So we've tried to now dive into more minimally invasive approaches. And initially there was what was called the 2-portal technique, where we used a camera and we actually were able to use 2 incisions on both sides of the heel to look at the plantar fascia and actually utilize the camera to do the dissection and actually cut that area of the plantar fascia under direct visualization with the camera, but keeping the incisions to about a centimeter on each side. And then more recently, with the invention of these needle scopes, so really small 1.9 millimeter cameras, we can now make an even smaller incision. And something that our group has written up and has published on is the uniportal technique, where we're now doing the same incision area where the big incision used to be, but now it's through, a couple millimeter incision. We put the camera in, we can see the plantar fascia, we can watch the blade go through right where we need to be in a controlled manner. And now you're not having that buildup of scar around there. It's less trauma to that surrounding tissue. And oftentimes you'll just need one little stitch. I typically tell patients they can generally start weight bearing within the first week, but they're a little sore just given like the nature of the injury and where we're operating. So they're in a soft dressing in a shoe, but they come back a week later, we take the stitches out. And then from weeks 2 to 4, they're really starting to put more and more weight on it. And then by 6 weeks, we really have them start ramping up activity and getting back to sport.
Yeah, that's super exciting. I think we've all been really excited about like the nano techniques, and there's so much evolution over time. So I haven't personally seen it, in this capacity. So it's exciting. And it sounds like obviously there's one, less sort of incision or portal, which is great. And it sounds like they're maybe weight bearing a little bit faster. Are there any other like benefits compared to the traditional endoscopic that you're seeing?
I think just in general, besides less trauma to the surrounding tissue, a little bit quicker return to activity, return to work, return to sport, less scar, less wound problems as well, just because this is an area at the bottom of the heel that can be really irritated, particularly if someone weight bears a little earlier. It can split open that incision, and we find that can be really problematic. So that also can help reduce, the risk of infection, and then also the need for revision surgery. We currently have a case series that just got accepted, which does show really overall 90% return to activity and good patient satisfaction scores. We haven't done a head-to-head though with regards, comparing to open, because honestly, I don't do the traditional open anymore because I see so much benefit with the smaller incisions. But I do tell patients this is something that even though it doesn't happen often, I will tell patients if they do have a little bit of pain even after the surgery, it's important to still supplement with physical therapy, with even heel cups initially, like almost starting from scratch a little bit after the surgery, where they need to, give it a little TLC, some soft tissue massage, and get them back, in a graduated manner.
Makes sense.
So I found your paper very interesting. And of course, like all technical articles, it makes it look like, oh, I could do this in my clinic. But for our foot and ankle, which I could not. But for our foot and ankle enthusiasts that are listening, what are some pearls and pitfalls that you want to tell them when adopting this technique in terms of like portal placement, things to watch out for, nerve risks, things like that?
Yeah. So I think one of the things as far as portal placement is right over where someone would do their injection. So right over the insertion of the plantar fascia on the medial aspect, you're looking at that glabrous skin. You want to go just above that to make that incision. And I typically will use some sort of mosquito to spread down to bone, just so that we can get down to where we need to be. The system we use has a dilator, which will help open up the area to allow for room for the camera to be placed in there. And then once you get the camera in, you're really able to see the plantar fascia itself. And that way you're able to visualize that you're not near any nerves. If you're in there and near a lot of fatty tissue, then you might not be in the right spot. And so I think that's really important. With regards to setup, I usually have the patient, just supine, laying on the table. You can do this actually wide awake if you want to. If you were looking to do this in your clinic room versus in the operating room, a lot of patients want to have a little bit of sedation, but you can do it under local. I typically will either not use a tourniquet, or I'll use just an S-mark ankle tourniquet, just because sometimes it can get a little oozy. But you can do local and have a little bit of epinephrine in there too. I try not to do do the local directly to where I'm actually injecting, because I found that if I inject it right where I'm going, it actually can cloud up the camera, which is something that I didn't realize until I tried it. And then I realized, okay, now that's a little bit of a wetter screen. So it's actually easy to do more of like a V-shaped local in the area and not where you're going to be putting your camera in. And I do think making sure you do pretty good in stitches. If you need to do a deep stitch, it's important, particularly if you're going to allow them to weight bear, because once again, I've had patients where if they've done a little bit too much too soon and they started splitting open the incision, and I had to reel them back in because they were just doing too much. And so I would say make sure that you're reinforcing that incision with the appropriate stitches.
Yeah, that makes sense. And I think sometimes, you learn things as you go, like the injecting, and that's how, we get better. So, so let's finish up our conversation today, which is like a quick discussion on the post-op recovery, rehab, especially like return to sport. It sounds like you have a lot of runners. What sort of expectations do you set for them with like the endoscopic technique? What does your post-op protocol look like?
Yeah, so typically I have my patients in a soft, bulky dressing with this post-op sandal looking shoe, very stylish. I always tell them they can bling it up if they want. And I tell them, I give them crutches and I say, just be protected weight bearing. You can put a little weight toward the outside of the foot. I don't want them changing their gait, extremely though, where they're having ankle issues, but they can technically put a little weight on it within the first day or two, but utilizing the crutches. I then have them come back 7 to 10 days later, sometimes a week later, just to look at the incision and take down the dressing and leave the stitches in actually a week. Because once again, I've learned the hard way that I need to leave it in longer. And so I'll let them though take the dressing down so they can start showering and slowly start putting more and more weight on it, come back that following week to take the stitches out. And usually once the stitch is out, patients can start slowly getting into a comfortable sneaker. I tell them that they should not be walking on hardwood floors barefoot. They should be wearing that cushion support. So similar to what we want even before the surgery, really babying that, but starting to really think heel to toe. I start physical therapy with it in 1 to 2 weeks. A lot of this is just gentle soft tissue work. Because this is an area of the skin at the heel pad that really gets really thick tissue just because of the nature of having to stand on it. I do tell them once the skin starts healing to gently massage the scar area, because you can get a big scar ball under the incision, which can cause pain in that region. So they rub this out. And then from weeks 2 to 6, they're gradually increasing activity, starting on a stationary bike, an elliptical, treadmill walking. By 4 to 5 weeks, if they're feeling pretty good, they can start ramping up. I've had patients who start running within 2 weeks, and I've had patients who need 6 to 8 weeks before they really even start doing that type of activity. I do find patients who've had the symptoms for longer tend to have a slightly longer recovery. And this is more level 5 evidence. So if they've had this heel pain for 2 years, I find they might fall into that 3-month category where they're really happy that they did the surgery. Whereas people who've had it maybe under a year, or maybe not as severe, and that release is all it took, then within 2 to 3 weeks, they're like running around. I mean, I remember I had one person come in a week later in his Crocs, and I was like, you're not even supposed to have the dressing off yet. And I'm just like shaking my head, but he was doing okay. So it was all right. But once again, variable though. But typically, because we're not repairing anything, we don't have to wait for, 6 to 8 weeks before we get them moving. I want them moving really quickly, and I don't want them to scar in. So they need to start doing soft tissue work really quickly.
That's great. Makes sense.
That was an awesome overview of everything. Thank you so much for taking the time to join us and go through all of this with us. Plantar fasciitis is something we see a lot, like across our clinics, and now having this like comprehensive understanding on conservative and surgical treatment is just really helpful. So thank you so much.
Thanks for having me. I really appreciate being here.
You're so great at explaining things. I'm sure your patients love you. You're just so good at sort of making it all make sense. So thank you. We really appreciate you.
Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love your feedback.